So it's my great honor and pleasure to introduce our next speaker of the talk, Dr. Mitchell Elkind, who's going to discuss cryptogenic stroke, the ARCADIA trials update. Dr. Elkind really needs no introduction because he's so famous. Just so for people who's outside the field of stroke and neurology, Dr. Elkind is a tenured professor emeritus of neurology and epidemiology at Columbia University. He was a founding chief of the Division of Neurology, Clinical Outcome Research and Population Sciences, so-called NeuroCorps, in Neurology Department at Columbia. Dr. Elkind also served as the president of the American Heart Association from 2020 to 2021. He's only the second neurologist ever to do that in American Heart's 100-year history. After beloved Dr. Sacco. After completing his term as president, he joined the AHA in a new executive position, the Chief Clinical Science Officer, with the vision of expanding the work of the organization from its traditional focus on cardiovascular disease and stroke to brain health more broadly defined. Dr. Elkind received his medical degree from Harvard Med School and trained in internal medicine at Brigham Women's and neurology at Mass General, both in Boston. He completed a fellowship at vascular neurology and neuroepidemiology at Columbia University Medical Center. Dr. Elkind holds a master's degree in epidemiology from Columbia Maimonides School of Public Health. His research focuses on stroke prevention, inflammation, infectious biomarkers in stroke, risk prediction, arterial atrial cardiopathy, immune therapy for acute stroke, and vascular causes of cognitive aging. Please welcome Dr. Elkind.
Terrific. Well, good morning, everybody. And thank you, Tony, and thank you to Dan Rosenbaum for inviting me to be here with you today. And thank you to Belly and Raina for getting me here this morning. It's really especially a pleasure to be here today because my dad did his residency in internal medicine here at Maimonides about, 60, 65 years or so ago. So it's a bit of a homecoming, if you will. So really thrilled to be with you all, and thank you for being here. So here are my disclosures, and a couple of these are relevant to the ARCADIA trial that I'll be focusing on today. BMS Pfizer did provide drug for the trial that I'll talk about, and Roche Diagnostics provided some ancillary support as well. So these are the things I want to talk about. I'll just do a little bit of level setting about cryptogenic stroke, and then we'll talk about atrial fibrillation, then this idea of atrial cardiopathy, then we'll talk about ARCADIA and potential future directions as well. So here's an example of cryptogenic stroke. This MRI is from a patient who was 57 years old, had left arm and hand weakness and numbness. Symptoms resolved very quickly, went away, and you can see he has this small superficial infarct, surface of the brain, right in that so-called hand knob area that was responsible for his symptoms, and nothing turned up on evaluation. Dr. Moore, who is currently, who retired just about a year and a half, maybe 2 years ago, is the former director of the stroke program at Columbia University, where I did my fellowship. He described this condition many, many years ago in the stroke data bank and gave this name to it. And in the so-called TOAST criteria that many of us use to classify stroke, cryptogenic stroke is similar to this idea of ischemic stroke of undetermined origin. Basically, it's a stroke that can't be attributed to large vessel disease, cardiac embolism, or to small vessel disease. And then it says, after an extensive evaluation, an incomplete evaluation, or evidence of more than one competing cause. So if you have carotid, significant carotid stenosis, as well as, let's say, atrial fibrillation, you don't know which of those was the cause of the stroke, then that would also count as undetermined origin. It's a little bit funny though, right, to say that a stroke is unexplained if you haven't done an evaluation to look for the cause. And so that's always been one of the problems with the TOAST criteria, and that's what led to this idea of ESIS, right, or embolic stroke of undetermined source. So the idea with ESIS, when you call somebody's stroke an ESIS, is that it's not a lacunar stroke, that there's no significant stenosis in either the extracranial or intracranial arteries of the brain in the area supplying that territory of the brain of at least 50% or more. So it has to be less than 50%. And there's no major risk cardioembolic source of embolism based on an echo, can be just transthoracic, and at least 24 hours of monitoring to exclude atrial fibrillation. And there's no other specific cause like dissection and vasculitis and so forth. So it really tries to pin down the particulars of how we arrive at that evaluation for the unexplained stroke. Now, this entity is not uncommon. This is data from the Northern Manhattan study, and the picture there is Ralph Sacco, who, as Tony graciously mentioned, was the first neurologist to serve as the president of the American Heart Association in its 100-year history. Ralph passed away, unfortunately, 2 years ago of a brain tumor himself. But he founded the Northern Manhattan Stroke Study, and it's still running now about over 30 years later. He founded it in the early 1990s. Within Northern Manhattan, about a third of strokes were considered of undetermined cause. Now, I think it's important when thinking about ESIS to recognize that it's not defined by its size. So here's an example of a lacunar infarct, right? Small, deep infarct, left side of the brain. And here's that same patient I showed you before, the stroke on the right side of the brain, superficial. It's the exact same size. I feel that sometimes radiologists may refer to a small stroke as being a lacunar because it's small, right? We say small deep infarct, we say small infarct, lacunar, but they may refer to it as a lacunar even if it's on the surface of the brain, right? So I just want to make the point that the size is not the defining characteristic. It's more than that. Unexplained strokes can be quite large as well. Here's an example. This was a 78-year-old man who saw his primary care doctor because he was confused. They sent him for an MRI a couple of days later, and it showed multiple infarcts in the right hemisphere. And then he was sent to the neurologist, who discovered that he actually did have a little bit of weakness on the left side, and then he was evaluated. There was no discovery at that time of the cause of his stroke. He actually underwent cardiac monitoring, and months later was found to have atrial fibrillation. We'll come to that. But here's quite a large stroke, actually. Interesting that he had such subtle symptoms from it. But these infarcts can be small, they can be large. What defines it is really its location. Location, 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 right? That's what stroke is all about. So we say that these small deep infarcts, the lacunes, are due to occlusion of one of these tiny penetrating vessels that goes deep into the territory of the brain, whereas these surface infarcts, the end vessels of the large vessels of the circle of Willis, like the middle cerebral artery and so forth, that's the location for a small embolism or ESIS. And then you can have larger ones when you involve those branch vessels as well as the middle cerebral artery stem. So if a clot is sitting in the stem long enough, it can occlude multiple perforators at the same time and cause a large deep infarct. So that's what we're seeing there. So ESIS is characterized by location. Another important point, I think, is that it's not characterized by just the presence of risk factors. You know, people come into the hospital, they've had a stroke, maybe they're obese, they're diabetic, they have hypertension, maybe they smoke, and we say, oh, we know why they had a stroke. It's because, you know, the lifestyle, they're just not healthy. They have all these different cardiometabolic risk factors. And that may be true that they have those, and those are risk factors and they contribute, but it doesn't mean that they can't have a specific mechanism of the stroke as well. So we still look for carotid disease, atrial fibrillation, and other causes as well. So when I think of managing a stroke patient for secondary prevention, I think of it on two tracks. One is identify the mechanism so that if there is one, we can treat that specifically. And let's not also forget about the importance of the risk factors and manage those too. Now, in the era of endovascular thrombectomy, we have some interesting further data about these patients with unexplained strokes because we can actually look at the blood clots that are taken out at the time of the procedure. And when people have done this, as this group from Germany did, they found that if you analyze those clots under the microscope, the blood clots taken out of patients with unexplained stroke look very much like the clots taken out of people with definite sources of cardiac embolism, like atrial fibrillation, for example. And so this supports the idea that ESUS is, in fact, an embolism from the heart. Let's see, I'm trying to advance it, and it's not responding. I see, great, thanks. So what are the causes or potential causes of ESUS? You can see a long list here, and thankfully we're not going to go through all of these right now. That would be a lot. And on top of these, there are things we don't know about as well, the unknown unknowns, as our former Defense Secretary Donald Rumsfeld used to say. But what we are going to talk about is atrial fibrillation and really this notion of atrial cardiopathy as well. So here's your first question, and we won't do the official, checks to see what everybody is saying, I guess. But in patients with ischemic stroke or TIA, and which of the following conditions is oral anticoagulation recommended? Paroxysmal AF, persistent AF, permanent AF, atrial flutter, or all of the above? So you think about your answer in your head. The correct answer is E. All of those are. Now, let's go through a brief history of atrial fibrillation and stroke. So back in the 70s and 80s, the association between AF and stroke was first recognized. So as Tony said, I did my residency at Mass General Hospital. I was fortunate to catch the very tail end, the Emeritus period of Dr. C. Miller Fisher, who described so many of the stroke syndromes and risk factors and so forth for stroke. But he also was there at the beginning of recognizing this association between AF and stroke. And, there are these apocryphal stories told about him sitting down at the physician's lunch table and talking to a bunch of cardiologists and talking about how he had seen in the path lab, because he loved to get the brains of his stroke patients after they died and analyze them under the microscope to see what had happened. So he talked about cutting the blood vessels of people who had died of stroke and finding embolic material in those. And he describes how at one point, 3 patients in a row came in with blood clot, fresh blood clot in their middle cerebral artery, and each of them had atrial fibrillation. So he told this group of cardiologists about this and said, I think atrial fibrillation causes clots that then go to the brain and cause stroke. And they all laughed at him and said, no, no, no. What causes stroke is vasospasm, because that was the prevailing idea at the time, that the vessels just clamp down. So it turns out that all 3 of those cardiologists went on to have cardioembolic strokes from atrial fibrillation, and C. Miller Fisher did not. So that's kind of a funny end to that tale. But he did appreciate that connection early on. Subsequent decades, we showed that warfarin was better than aspirin for preventing stroke. We recognize that paroxysmal atrial fibrillation is also a risk factor for stroke. You don't have to have it consistently. It can come and go. We have different ways of looking for it. And then, of course, more recently, the new oral anticoagulants, CHADS2-VASc, and other risk prediction scores, and a discussion about AFib burden that will come up. Now, the cardiologists have all these different categories of atrial fibrillation that I had in the question. And that's all well and good, and how long it sticks around for and so forth. But I would say that for us, as neurologists or people taking care of stroke, what most concerns us is this idea of occult atrial fibrillation, right, which is not an official category, but essentially refers to atrial fibrillation that's hard to find, right? Atrial fibrillation can be very brief. It can occur for seconds and go away and, occur infrequently. So once every several weeks or months, for example. And so it's still an ongoing debate. How much AFib do you have to have before we say you have atrial fibrillation and do something about it? Well, why does it matter? It matters because atrial fibrillation is still the only cardioembolic, really the only stroke cause for which anticoagulation has been shown to be of benefit. And it has a strong benefit compared with placebo, about 60 to 70% risk reduction, compared to aspirin, about 40%. So it's important to find it, but as I just said, it can be hard to find it. Much of the time, people don't even know they have it until they have their stroke, and then the AFib is detected. So it can be hard to find, and that's where all of these new monitoring approaches have come in. So in the first trial that explored the relevance of cardiac monitoring, the Embrace trial that was done in Canada, they took about 570 patients with unexplained stroke within the last 6 months. They had to be over age 55, so there was an average age of 73. Their evaluation had been negative. Notably, Canada, they don't do as much TEE, so only 8% of them had had a transesophageal echo. And the patients were then randomized to standard monitoring of 24 hours in the hospital, right, while they're in the bed, compared with a 30-day event-triggered monitor. And the primary outcome was 30 seconds of AF by 90 days. The idea was that, yes, obviously you're not going to find AF on a monitor in people who are only getting 24 hours of monitoring, but otherwise people are going through their lives, they're having symptoms and spells, and they get EKGs and so forth. So which of these strategies was more likely to pick up 30 seconds of AF by 90 days? The 30-day monitor was much more effective. You can see here 16% versus 3% with the standard approach of 24 hours. That was true if the length of AF were longer, 2.5 minutes, or any AF for that matter. And there was also an increased likelihood of patients being changed from antiplatelet to anticoagulant therapy in response to the discovery of the AF. Another study published around the same time was the Crystal AF study. This one looked at 440 cryptogenic stroke patients. They were younger, they had to be at least 40, so the average age was 61 versus 73 in the other study, so 10 years younger. And everybody got a transesophageal echo in this case. And they compared that same 24-hour standard monitoring to an implanted cardiac monitor that could remain in place for up to 3 years. The battery life was 3 years. And they looked for AF episodes of 30 seconds as well. The primary outcome was how much AF was there at 6 months. And what they found was that putting an implanted monitor in, also much more likely to find AF, 6 times as likely to find those 30-second episodes by 6 months. And if they looked out further, up to 3 years, 30% of those with the monitor were found to have AF versus only 3% in the group of standard care patients, right? So 10-fold increase in the likelihood of picking up AF. And that, of course, is why we do so much of this implanted cardiac monitoring to look for AF now. In that study also, it wasn't powered to look at stroke outcomes, but there was a suggestion that those who had a device placed were less likely to experience a recurrent stroke. But again, wasn't statistically significant, and that was not the purpose of the study. So from those two trials, we know that 30 days of monitoring is better than 24 hours. We know that 3 years of monitoring is better than 24 hours. And we know that detection of AF can change management. But we don't yet know whether 30 days is better than 3 years, and if it reduces risk of stroke or not. And because we don't know the answer to that clinical question of a clinical outcome like stroke, monitoring is recommended as something you could consider, long-term monitoring, you could consider it, it says in AHA guidelines, but it's not the highest level of recommendation because it hasn't been proven in a clinical trial with those kind of clinical outcomes. All right, so that's atrial fibrillation, important topic, and as you can see, questions about it have been going on for a while. But let's go back to the result I just showed you. 30% versus 3% at 3 years. 30% is a good number. That's a lot of AF and stroke patients. But that still means there's 70% of patients out there who didn't have the AF. So the question is, what else might be out there? What are we missing? And this raises this question of what we'll call atrial cardiopathy, right? So in the traditional notion of atrial fibrillation, the heart is fibrillating, right? It's not pumping regularly, it's quivering. Blood clots can form, and they can then go to the brain and cause emboli. In studies, though, where they have people who have implanted cardiac monitors for other reasons, like pacemakers and defibrillators and so forth, they have accumulated data over a period of time. They could look at the relationship of when people with paroxysmal AF were in AF and when they had their stroke. And what becomes clear quickly is that people don't necessarily have their stroke in close temporal proximity to when they're in the atrial fibrillation. So they could be separate, those two things, having AF and having a stroke could be separated by as much as 30 days, 90% or more of the time. Okay, so that kind of makes you wonder whether it's truly the AF that's causing the stroke or something else. So temporal dissociation is important. Also, it's known that people who have ectopy, even if they don't have atrial fibrillation, if they have premature atrial contractions or runs of PSVT and so forth, can have a stroke before they develop the AF itself. Genetic mutations that lead to atrial fibrillation, similarly associated with risk of stroke without frank atrial fibrillation. And in the setting of cardiac procedures, people can have electromechanical dissociation of the surface EKG that's telling you the rhythm and what the mechanics of the heart look like. So the mechanics of the heart, you do an echo at the time, show atrial fibrillation, but the EKG is just sailing along in normal sinus rhythm, right? So something is wrong in the atrium, but your EKG isn't telling you that. So that's why Houman Kamel at Cornell, who I'm sure many of you know, and others of us question this idea that you have to have atrial fibrillation itself to have the stroke. And instead, might it be not just this quivering bag of worms, like we used to say in medical school, but just that structural or functional abnormality of the underlying atrium that can lead to the stroke. And there are a number of different mechanisms that could account for it: fibrosis, decreased function of the heart cells, stasis, even without the fibrillation per se, endothelial dysfunction, inflammation, and hypercoagulable problems as well. And so if we rethink the idea of how AFib leads to stroke, imagine, people develop risk factors over the course of life that can lead to atherosclerosis, lots of other reasons for people to have a stroke. It can lead to an abnormal atrium that can then go on to develop atrial fibrillation, and that can lead to stroke. So this is the conventional traditional model, but we hypothesized maybe that abnormal underlying atrial substrate can lead to stroke directly without going through the atrial fibrillation pathway. And again, there's evidence to support this. This was a neat analysis that Houman did, looking at data from the California statewide database, looking at people who had paroxysmal supraventricular tachycardia, but never had atrial fibrillation. This is all based on administrative diagnosis codes, but they're, you can see it's almost 5 million people because it's all the admissions to the hospitals in California. So if you were hospitalized with PSVT, but never had a hospitalization for AFib, compared with those who were never hospitalized with either, you were at about twice the increased risk of having a stroke. Okay, so we don't anticoagulate PSVT patients. Is this a reason why we should, perhaps? Unknown. You can look at the EKG itself. So if you look at the 12-lead EKG, lead V2 sits over the left atrium. Lead V1 rather sits over the left atrium. And so you can look at what's called the P wave there. And so the P wave goes below the horizontal meridian, and it has a depth and a duration. You can measure those using a calipers and come up with your P wave terminal force. So telling you about the function of the left atrium. And we had a very ambitious undergraduate student join us in the Northern Manhattan study at Columbia, who went back and looked at all our stored EKGs and measured with the digital calipers those P waves that, when we collected them, nobody cared about that. But she went back and looked and found that increases in that P wave terminal force were associated with risk of stroke and were specifically associated with risk of cardioembolic or cryptogenic unexplained stroke. So these were taken, the EKGs were from years before the stroke happened, but something was brewing, let's say, in their left atrium before they went on and had the stroke. One can measure biomarkers like high sensitivity cardiac troponin or NT-proBNP, a measure of cardiac wall stress and volume, obviously used in heart failure. And that can also serve as a marker and is associated with risk of stroke, even after adjusting for AF and heart failure and left ventricular hypertrophy as well. This is data from the cardiovascular health study. So we had this idea that, yes, there's some atrial fibrillation you know about because the person has a history of it. It comes and it goes, perhaps. There's this concept of occult AF, which may then take you a little bit below the water. These are people who you find the AF when you do your monitoring. But then might there be a whole group of people who have biomarkers or indicators of some other atrial dysfunction who don't yet rise to the level of the surface with the atrial fibrillation? Now, we know from two very large industry-sponsored studies in this area of unexplained stroke, ESUS patients, that anticoagulation is no better than antiplatelet therapy for these patients, right? So Navigate ESUS, which looked at rivaroxaban, and Respect ESUS, which looked at dabigatran, tested the idea that if somebody had a stroke, probably a clot somewhere, could be anticoagulating those people. Most of them are probably emboli, let's anticoagulate. But as you can see, that didn't turn out to be the case in those trials. And so that led people to question whether, in fact, one should separate. We shouldn't be lumping all these ESUS cases together and saying what's good for one is good for all, but instead trying to divide them in some meaningful way. Maybe those with cancer and PFO and this atrial cardiopathy and atrial fibrillation, maybe they should be anticoagulated, but others who have underlying athero may in fact do better on an antiplatelet agent. Okay, so speaking about antithrombotics and antiplatelets, question 2 here. In patients with ischemic stroke or TIA and non-valvular AF, which of the following classes of agent is recommended? Vitamin K antagonist, thromboxane A2 inhibitor, right? That's aspirin. Direct thrombin inhibitor, thienopyridine P2Y12 receptor inhibitor like clopidogrel, or a phosphodiesterase inhibitor like dipyridamole. So you think about it, which would you say? This is for a patient with stroke and AF, and the correct answer is C, a direct thrombin inhibitor, right? Dabigatran is actually a direct factor 10 inhibitor. That's fine too, but direct thrombin inhibitors are included in there, and these are now the standard of care for patients with AF, right? So it's not warfarin or a DOAC, it's a DOAC. Dabigatran, apixaban, edoxaban, rivaroxaban, those are all acceptable recommendations. Okay, so that's AF. What about in patients who don't have AF? So several of you probably remember the WARS study. I know Dr. Levine does. The WARS study goes back to the early 2000s. It was run by Dr. Moore. Dr. Moore also trained at MGH under C. Miller Fisher. MGH, we know, stands for must give heparin, right? We anticoagulated all patients back then. Dr. Moore said, well, we need a study to prove if this is true or not. So he ran the WARS trial, which compared warfarin to aspirin for patients who didn't have AF and were not about to undergo carotid endarterectomy. So like all of those other stroke patients, is it true they should be anticoagulated? Here's the answer. The answer was no. Patients who were randomized to warfarin actually did worse than the patients who were on aspirin, and there was an increased risk of bleeding among them as well. So that was one of the, nails in the coffin, if you will, of anticoagulant therapy for patients with ischemic stroke. But Some added benefits of that trial, rising like the phoenix out of a negative study is the potential for new opportunities and new trials. We had stored blood specimens because they had been measuring INRs in all the patients in wars. And what was found was that when we went back and looked at the blood samples and ran them for NT-proBNP, patients who had elevations in NT-proBNP did get a benefit from being on anticoagulation. They were at lower risk of having a stroke or dying. And so this led us to think maybe there is a subgroup of patients who benefit, those who have evidence of NT-proBNP being elevated, perhaps this group of atrial cardiopathy patients. Many years have passed since wars. Back then, there were no DOACs available. Now there are, and the DOACs are also safer, right? They have a lower risk of hemorrhage. They're as effective as warfarin, in some cases more effective, and they have about half the risk of intracerebral bleeding as warfarin. And so the question was, might there be an opportunity then to re-ask similar questions using these new agents? We also had some evidence from the Navigates study that patients with very enlarged left atria, this was also a secondary analysis, another phoenix rising out of the dust, if you will, out of the fire, I guess. And that showed that patients who had very enlarged left atria also saw a benefit from being on rivaroxaban, a DOAC, instead of aspirin. Secondary analysis can't put it in the guideline, but you can work with it. So that led Human and Will Longstreth, Dave Tershwell, and I to put together this trial called ARCADIA, Atrial Cardiopathy and Antithrombotic Drugs in Prevention After Cryptogenic Stroke. So this was a multi-center randomized trial. It was run through the StrokeNet mechanism, right, funded by the NIH. We did get support in terms of drug, as I mentioned at the beginning, from BMS Pfizer Alliance, as well as a little bit from Roche. And the main hypothesis was that apixaban would be better than aspirin to prevent recurrent stroke, specifically in patients who had unexplained stroke and atrial cardiopathy. So that was the main hypothesis of the study, that it would be basically apixaban would be better than aspirin for these patients, just like it is in atrial fibrillation. Patients had to be at least 45 years of age. They had to have an unexplained stroke. They had to get treatment started within 180 days. And then how do we know if they have atrial cardiopathy? It's not something you can ask a cardiologist. There's no formal definition. So we used biomarkers. They had to have at least one of these three biomarkers: an increase in that P wave terminal force in V1 that I mentioned, that I showed you, an elevation in serum NT-proBNP, or severe left atrial enlargement. This was a stroke study. We were focused on stroke as our primary outcome. So what happened in the trial? Well, 1,000 people were enrolled, followed up for almost 2 years on average. And then the DSMB stopped the study, not because of any safety concerns, but essentially because there was no evidence of any benefit. Here was the breakdown of patients in the study. You can see the average age, about 68. There was good race ethnic distribution. We had about just over 20% were Black or African American, and we had almost 10% Hispanic or Latino. Here you can see the different prior conditions people had. There was a relatively high burden of prior stroke, 19%, 11% ischemic heart disease, 78% had hypertension, 30% had diabetes, and 45%, almost half, were smokers. So a lot of other cardiovascular risk factors in the mix. We'll keep that in mind. Here are some of the other measures. First of all, these were mild strokes. NIH stroke scale on average was 1 at the time they were randomized. On average, that occurred about 60 days after the stroke had happened. And you can see here the reasons why people got into the trial. Most of them got in because they had an elevated NT-proBNP, a smaller proportion because of the EKG. Very few got in because they had severe left atrial enlargement. And the reason for that, we think, is that most of those who did either had AF already, or their doctors weren't comfortable putting them into the trial, or they got cardiac monitoring that quickly showed that they had AF. And so severe left atrial enlargement may have been a criterion too high, if you will. And here's the main result, the Kaplan-Meier curve. You can see that really no difference between the aspirin and apixaban through the course of the study for the population overall. There was about a 4% per year risk of stroke in these patients, no different between the groups. You can see similarly for the secondary efficacy outcomes. Safety was fine. There was no increased risk of bleeding, at least no statistically significant increased risk in bleeding. Bleeding rates were low in the trial, so that wasn't the problem. So what do we conclude from ARCADIA? Well, number one, there's no benefit of apixaban over aspirin in patients who have ESUS and evidence of atrial cardiopathy based on the biomarkers we used. And there are no significant safety differences between the two drugs. So those are our main conclusions. What does that mean? Well, it could mean that we were just barking up the wrong tree, and atrial cardiopathy is not a cause of stroke. It could be that atrial cardiopathy, yeah, might be a cause of stroke, but it's not clear that anticoagulation is any better than aspirin in preventing the next stroke in these patients. It could be that we're up the, let's say, up the right tree, but the wrong branch, okay? We chose the wrong biomarkers. That's possible. Maybe we chose the wrong outcomes. Maybe we were thinking about the time windows incorrectly, and our threshold for anticoagulation may need to be a little bit different. So I want to kind of touch on each of these in turn. So what I'm about to show you are hypotheses, right? This is hypothesis generating data. So anything I show you now, don't say, well, Dr. Elkind said I should do X, Y, Z because this is what the data show. This is all secondary analysis, okay? It's, to get us to the next study, which hopefully, right? Hopefully there will be future studies, but that's a separate topic. Okay, so wrong biomarkers. Well, it could be that NT-proBNP and the other measures was the wrong marker to use. Maybe we should have used a different one that a colleague in Switzerland is using called mid-regional pro-ANP, which shows much the same thing. And she has used it to show that you can predict who doesn't need to be monitored for AFib because their levels are so low. But we did show in our trial, looking at secondary analyses, that NT-proBNP was associated with risk of recurrent stroke. So it did predict recurrent stroke. We also know that it predicts atrial fibrillation in our trial, because while we were doing the study, people were being monitored. We didn't exclude monitoring from the patients. It was up to the doctors to do what they wanted to do. So some of them developed AFib, and so we could see what the predictors of AFib were. And this was work that Human did. And so NT-proBNP also predicted atrial fibrillation, even after adjusting for other risk factors, and in fact predicted it pretty well. So you can see the area under the curve, statistics here, about 0.82, mostly driven by the presence of NT-proBNP. The addition of other measures like age and left atrial diameter really didn't change much. We also did some further analyses that we hadn't thought of initially, to look at some of the additional rhythm information we got just from the simple EKG, right? This was just a one-time EKG that we were using. And none of our markers, if you think about it, really reflected rhythm per se. They were just like point-in-time blood test, EKG, what a wave looked like, and an echo. But we could look just within the 30 seconds of the EKG and see how many people had premature atrial contractions and how many were present. And so a couple of investigators at Stanford went back and reanalyzed EKGs and reported on that. And so those who had at least one premature atrial contraction were at increased risk of going on to have a stroke. Okay, there was no effect of anticoagulation in that group of patients, but the outcomes were small, but there was an increased risk of stroke. There are other measures that we're still analyzing now. So left atrial strain is a measure of the left atrium. You can see it on echo. It has to be interpreted differently. It's not part of the clinical interpretation usually, but our echo core, which retained all the echoes from the study, is rereading those echoes to measure left atrial strain. And when left atrial strain is low, that indicates dysfunction of the atrium and an increased risk of stroke. These data, I should have said this at the start, this is not from our trial. This is from the Northern Manhattan study, or the CABLE study, which is a sub-study looking at cardiac features and their risk with stroke and dementia. So in that study, left atrial strain is associated with risk of stroke. And the Marco Di Tullio, who is the echocardiographer for NOMAS, is also doing that for ARCADIA and is reading our echoes there. And this is something we've tried to do, but the EKGs we collected are not great for it. It's called EKG AI. It's basically taking EKGs, subjecting them to AI, and with that, you can determine somebody's subsequent risk of having atrial fibrillation. I was telling Steve this before. With an EKG, you can tell with really pretty good accuracy what sex somebody is, how old they are, what they had for dinner last night. It's really pretty amazing what AI is able to do with EKG-based data. I was just joking about the dinner last night, by the way. But it can tell you somebody's subsequent risk of developing AF. It can also tell you their subsequent risk of having a stroke, and tell you people who won't have a stroke as well. So one could imagine, again, not sure we'll be able to do this, but one could imagine taking EKGs, just single EKG the day somebody comes in with the stroke, subjecting it to this AI algorithm, and it will tell you, oh, this person has an 80% chance of having AF in the next year, or this person has a 2% chance in the next year. That might tell you something about whether they should be tested more or even anticoagulated. So not there yet, but coming soon. Okay, so there are some things that are unrelated to the atria as well that we looked at. So we know from prior analyses that people who have left ventricular dysfunction, right, elevated or decreased left ventricular ejection fraction, for example, are at increased risk of stroke. And there's some evidence that anticoagulation helps those patients as well. And so using those same echoes, we could look at left ventricular dysfunction defined in a number of different ways. And Richa Sharma, who's at Yale, did an analysis showing that if you had left ventricular systolic dysfunction, low EF below 50%, or left ventricular fractional shortening of less than 25%, or regional wall motion abnormalities, your risk of having a stroke was higher than if you didn't, right? So left ventricular function predicted the risk of stroke. It wasn't significant in all of these because the number of outcomes was small, but it was for the low EF, and you can see that here. So even after adjusting for other risk factors, over twofold increase in risk of stroke. And she also looked at the effect of therapy. So if you had left ventricular dysfunction, would apixaban be better than aspirin? And so the relevant contrasts here are the red. It's hard to read the letters, I know, but the red and the blue. So basically, if the red lines here are if you have adverse left ventricular function, and the blue, and you're on aspirin, and the blue is if you're on apixaban, right? So if you didn't have left ventricular dysfunction, it didn't matter. But if you did have left ventricular dysfunction, then apixaban was more effective than aspirin for these different groups. And again, it wasn't significant for all of them, but for that composite measure and for the fractional shortening, it was. So some noise in the data, but suggesting that left ventricular disease also predicts not only stroke, but a response to anticoagulant therapy. Babak Navi at Cornell looked at a history of cancer as a predictor of stroke as well, and found that a history of cancer in the cohort was associated with subsequent risk of stroke. There was no effective treatment in that case. Well, what I should say is there was a decreased risk of recurrent stroke if you had a history of cancer and you were on apixaban, but it wasn't statistically significant, again, because of small numbers. So some suggestive evidence that treating patients who have a history of cancer and unexplained stroke may lead to a decreased risk of recurrence. What if we chose the wrong outcomes, right? So we also had an ancillary study called ARCADIA CSI, which stands for cognition and subcortical infarcts. This was a small subsample of our total study. They had about 300 patients altogether, and I think 200 roughly who had MRI scans done at baseline and again at the end of the trial. So they were able to look at subclinical disease, the development of infarcts, even if somebody didn't have symptoms. And interestingly, what they found was that for those who had those who were on apixaban, there was a pretty marked decrease in risk of having a non-lacunar covert infarct. So they excluded recurrent lacunes, small vessel disease. We wouldn't expect that to be affected by anticoagulation, but they looked at people with those small superficial infarcts, and they found that if people were on apixaban, they had a decreased risk. So maybe we should have looked at subclinical disease as a possibility. And these were just subgroup analyses from them. What about the time window? Well, one interesting thing is here you can see an on-treatment analysis. So this is for people who were actively taking the drug. They didn't stop it. And this is the Kaplan-Meier curve. And what you can see here, which is like not something you want to see in a Kaplan-Meier curve, is that your curves cross, right? So in the beginning, aspirin in red is better. Sorry, in the beginning, aspirin in blue is better than apixaban in red. But then somewhere between a half a year and a year, apixaban becomes better and more events accrue on aspirin. And you can see here that although there's an overall benefit of apixaban versus aspirin, when we looked at the hazard ratio of all of the times together, in fact, they're behaving very differently before about 6 months and after 6 months. So before 6 months, aspirin is much better than apixaban. After 6 months, apixaban much better than aspirin. And in fact, after 6 months, there's even a statistically significant effect of apixaban compared with aspirin in terms of reducing the risk of stroke. So, you know, we don't usually think of early versus late when we're thinking about treatment. Somebody had a stroke, we start them on a medicine, they stay on it indefinitely. We do shift our treatment based on time for dual antiplatelets, right? We do aspirin and clopidogrel for, you know, up to 90 days, and then we'll switch to a single agent after that. That's what the guidelines recommend. But most of the time, once you're on it long term unless something else happens. But these data would suggest that maybe early on, right, soon after somebody's had an event, aspirin may be more effective. Why? Well, maybe because of all those atherosclerotic risk factors. 30% of our cohort had diabetes. And it may be that they have blood vessels that are inflamed or active in some way. It may even be that they actually had an atherosclerotic stroke with an unstable plaque, and we think antiplatelet therapy may be more effective in that setting. But as that settles down, longer term, the risk of anticoagulation, of atrial fibrillation and maybe atrial cardiopathy accumulates and increases. And so in the long term, an anticoagulant may be more effective than an antiplatelet. Hypotheses, but leads us to think about how we might design the subsequent study. And more generally, this brings up the idea that atrial fibrillation itself is not the same thing in everybody, right? When we detect AF after a stroke, that may not be the same as finding it beforehand, as somebody who comes in with a history of years of atrial fibrillation. There's this idea of AFDAS, AF detected after stroke versus known stroke. And there's evidence that those who have it detected after stroke have a lower risk of recurrent stroke occurring. Stroke itself can be a cause of atrial fibrillation. And so those patients may have a short period of time when they have AF, and then it goes away and isn't continuously a problem. So we should be thinking about AF more specifically. And in fact, there could be a spectrum of risk associated with AF. If we think of at the lowest end of risk, something like atrial cardiopathy, then paroxysmal AF, then persistent AF, and then permanent AF, the stroke risk goes up as you move to the right here. And it, you know, traditionally we thought antiplatelet therapy was fine until you got to paroxysmal AF. Our hypothesis was, let's go back as early in the disease process as possible to the atrial cardiopathy, you know, before there's real clinical manifestations, and anticoagulate those patients too. But it may be that we went too far, and in fact, we don't know where the threshold is to begin anticoagulation. It could be that paroxysmal AF detected after atrial fibrillation, maybe that doesn't need to be anticoagulated. Nobody's done a study of it because none of you, none of us, me, would not anticoagulate patients who were found to have AF after a stroke, right? Can you imagine doing a trial where you're going to randomize people who have 5 minutes of AF after a stroke, get anticoagulated or not? You know, I think it would be hard to argue that that would survive the standard of care. In ARCADIA, that was a trial among people who didn't have a stroke. They had a history of heart disease, and they had implanted monitors because of their heart disease. They randomly assigned people who had SCAF, subclinical atrial fibrillation, to anticoagulation or an antiplatelet. They did find a decreased risk of stroke in that group, but again, it's a different population of patients. So still unknown for stroke patients what we should do with the monitoring information we get. We assume we should anticoagulate them, but we don't really know. And again, that speaks to this question of atrial fibrillation burden. AF is not just a binary phenomenon. There's mild AF, there's a little bit of AF, there's a lot of AF, and probably those need to be treated differently. And we just need to figure out how to do that. So if we go back to the history of AF and stroke, you can see it here. I'll add to the current decades, the atrial cardiopathies. And I'll stop just by acknowledging collaborators at Columbia, University of Miami, Ralph Sacco, of course, who was, as I mentioned, the founder of NOMAS and a mentor to me and so many others, as well as our funding from NIH and other sources. And then CHS colleagues, Will Longstreth in particular, and then the ARCADIA team that I named before, and then our funding for ARCADIA from NIH, BMS, Pfizer, and Roche. And I will stop there, and if we have time, I'd be happy to take some questions. So thanks so much for your attention.
Wow. Thank you so much, Mitch. It's amazing discussions, landmark trials. It generated so many hypotheses after the trial. But I'll go first if I can. Do we have any questions in the audience to start with? Anybody? Let's check the Q&A session first. So what are percentage of accuracy with AI versus modern technology?
Yeah, so it's about 80 to 90%. So this is about that EKG AI, right? So how good is AI at telling you whether somebody's EKG predicts future risk of AFib? It's on the order of 80 to 90%, I believe, that AI, depending on the algorithm and the population, can give you that information. It's quite good.
Okay, so Dr. Sotento, the Shokotanian Maimo asking a question. What are your thoughts on management of patients with post-op TIA, transient AFib? Want to start the anticoagulation, controversial.
Yeah. So there are a number of settings in which AF can occur in hospitalized patients. Post-op, certainly. Sepsis is another common one that can lead to AF. And in the studies that have been done, those patients do carry with them an increased risk of future stroke. So especially after cardiac surgery, if you have transient AF, it is associated with a future risk. The risk doesn't just go away. Presumably something about having the surgery, it may just reveal an underlying risk, or it could be that something that happened at surgery caused some damage that leads to future risk. So those patients are at increased risk. You're right, there's not really been a trial. I think there might be some either in planning stages or being done now that are looking at post-op AF and whether they should be anticoagulated. That would be a good question to answer. My inclination has been to be pretty aggressive about anticoagulating those patients, as long as there's no bleeding risk to anticoagulate. But I know cardiologists probably don't do that as much.
We have a prominent cardiologist in the audience. So what is your thoughts about post-PFO closure AF and anticoagulation or not afterwards? You have different spectrum of aggressiveness.
Yeah.
Dr. Frankel.
Yeah, hi. Thanks very much, Mitch. Great lecture. So when we see patients who have atrial fibrillation, we have a pretty low threshold to start anticoagulation. If you were then to go ahead and put in a long-term device like that implantable device and you had the patient 3 years and you didn't see any atrial fibrillation, the question is, if you start it, when can you stop it? It's always a point of controversy, and I'm not sure myself, but we have a low threshold for starting.
Yeah, so that sounds pretty consistent, and I agree. If you go a long time and somebody hasn't had AF, they might come off it. There's a trial now, I'm blanking on the specific name of it. It's being run by Rod Passman at Northwestern, but it's basically looking at whether you can use continuous monitoring to decide when to start and stop somebody. So if you have a monitor in, it could tell you when somebody's in AF, and then you put them on the anticoagulant, and then when they come back out of AF, a few days later, you stop it. Several weeks later, it comes on again. They go back on the anticoagulant and come off. So that trial is going on just to minimize the amount of time somebody is being anticoagulated.
Interesting. So there's someone, I think Scott, in the chat group asking whether the slides will be available. Yes, indeed, it will be available. All the slides will be available. Actually, we have a repertoire of previous symposiums slides all edited and published. So you can go back to look at those lectures, including today's. Yes, anyway, a misspoke is not TIA, it's trends in AFib. So any data on stroke after ablation and for AF and strokes?
Yeah, so probably our cardiology colleagues can tell us more about recurrence of AF in people who've been ablated, because I had an episode of AF. I'll throw in my my 2 cents on this. I do know, I believe, that the rates of recurrent AF are fairly high in patients who've been ablated. I know that I've also had patients who were ablated, went on antiplatelet therapy and had events, TIAs, seizures that were presumed due to stroke because they had no prior history of stroke and so forth, or of seizures. Then when they get monitored, it turns out they're having recurrent episodes. So I think that I think it's higher than we have thought, is my understanding. I think many cardiologists would agree, but I don't know if all do.
So I'll start my question. I have quite a few, very interesting. So I consider myself, generally speaking, a very optimistic person and kind of minimalist as well. So the trial tells us the aspirin is not inferior to DOACs. But also on the other flip side is the DOACs anticoagulation doesn't actually cause more hemorrhage or mortality compared to aspirin. So to me, it's a glass 50% full or 50% empty. So most people are choosing the 50% empty side not to anticoagulate. Why don't anticoagulate? Because there will be potential proximal AFib patients be developed later on. Maybe that's the effect you're seeing after 6 months. And actually aspirin is preventing that transition. So maybe that's what we're seeing. And there's really no downside in anticoagulating them. Why not?
Yeah, so one could take that position. That's very similar to the position that Dr. Moore took after the WARS trial, which was warfarin was no better than aspirin, which is what he set out to prove, that it was better, but warfarin was no better. But it was about the same. The risk of bleeding was not that much. So he was going to continue recommending anticoagulation for these patients. But in a sense, that really, flies in the face of, if you will, the philosophical purpose, for which we do these studies and kind of the scientific method. These studies are not done to prove that these treatments are equal. They were done to show that one is better than the other. And all we can do is reject that hypothesis. And then we're back to where we started. And clinically, that is a standard of care. So our standard of care is, antiplatelet therapy. And so these studies that are done are to prove whether something is better than that. So the fact that something isn't better doesn't mean that it's just as good as necessarily. So, again, philosophically, you're right, practically speaking, free country, at least it used to be. We're free to do whatever we want. But that benefit or that interpretation isn't the kind of it doesn't really comport with the scientific method so much.
Right, I understand that. But on the other side is that what population did we detect who has the AFib during the study, percentage-wise?
Say it again?
What percentage patient actually developed AFib during the study period? Which they will be benefiting from the anticoagulation as opposed to antiplatelet therapy.
Yeah, it was about 15 to 20% who developed AF over the course of the study.
So if those patients, we can somehow detect them earlier, will that actually population sway the outcome if you do a subgroup analysis?
We did look for that, right? Because part of the idea was, sure, patients are going to develop AFib, but if they were in the study and they were at least on an anticoagulant first, the idea was, could you tell when somebody first came into the hospital that they should be on an anticoagulant? Yes, we know now that if you follow people over time, they develop AFib, they get started on an anticoagulant, that would be standard of care. But our goal was to show that we didn't need the monitoring because the biomarkers would tell you from day one if they should be on anticoagulation or not. So we did look, though, to see, was there a benefit in those who went on to develop AFib? And we didn't find it. It may, again, have been because the numbers were too small. A much larger trial might have shown that, but we don't have an answer for that.
So, Leah has a question. I don't want to hog the mic.
Sorry, Tony. I just got so excited to ask. Thank you so much. That was really a treat to hear about atrial cardiopathy from you, and great talk. Okay, so in the spirit of really not knowing what burden of AFib is the burden to be worried about, are you approaching patients after stroke with let's check biomarkers and not monitor, or are you still pursuing monitors? And if so, what are you using to guide your decision around 14 days, 30 days, loop recorder, 3 years?
Yeah, so that's a great question. And there are, some risk prediction schemes that will tell you how likely people are to develop atrial fibrillation. So those who are older, certainly, who have evidence of some cardiac dysfunction, who have other risk factors, CHADS2, VASC, which is really for patients who have AFib, but could also be used in people presumably who have had a recent stroke to predict AFib. If there are other features, then we would look harder. So it's sort of similar to what's been done with the risk of paradoxical embolism score for PFO. There are some people in whom a PFO is incidental and some in whom it probably is the cause. And the same thing would go for, detection of AFib, that you can identify some people in whom you should look harder for it. And I don't think there's yet like a commonly agreed upon approach to doing that, but a lot of these different patient characteristics, biomarkers, echo findings, et cetera, could be used for that purpose.
A couple more questions in the audience online. Is homocysteine a risk factor for cryptogenic stroke? Homocysteine.
I don't see.
Is homocysteine a risk factor?
Yeah. Oh, wow. That's a blast from the past. Yes, it probably is, but the magnitude of that is not high. So yeah, a lot of epidemiologic studies have shown an association with homocysteine, but in clinical practice, we don't test for it really.
Yeah, a couple more questions. So if patients have sepsis and AFib at the same time, do you still anticoagulate, for example, in the course of infective endocarditis?
Well, if somebody has AF in the setting of sepsis, they may be very sick in an ICU, and in that case, there may be a lot of other issues that would mitigate against starting an anticoagulant. They could have GI bleeding and so forth. So I think if the question is really, when they recover from the sepsis, the fact that they had AF, does it mean that they should be anticoagulated long term? We don't really know the answer to that yet. I think that's a good area for a trial. One of my other major areas of interest is how infection is a risk factor for stroke. And, something like sepsis, it turns out that when you have sepsis, your risk of not just stroke, but cardiovascular events, certainly it's elevated in the short term. We get that, right? You're acutely ill, you're metabolic system is off, your coagulation system is off. But it turns out that those factors actually persist going out for many years after the episode of sepsis. So this has not been proven yet, but in my mind, sepsis, may need to be thought of like a chronic risk factor in the same way we think about hypertension, diabetes, et cetera. Maybe we should be did you have a history of sepsis? You get a point on the scoring system for that. So I think we still need the kind of large-scale epidemiologic evidence and synthesize it all to do that. But I think eventually we will get there, and sepsis may be an example.
Like COVID.
COVID. 100%, exactly.
Risk factor, potentially long COVID and long lasting.
Yeah, right.
So in the studies, there are population that's 20% or so, 19% they have recurrent strokes before. So if we analyze those patients, subgroup analysis, do you see different treatment effect between?
We did not. Yeah, we looked and we really didn't see any significant subgroup differences in the overall analysis. The on treatment, things start to separate out. There were some differences between men and women. The problem is the numbers are so small, the confidence intervals become very wide that it's hard to draw conclusions from that.
Small size. What about the, why did we pick a 250 as a cutoff as opposed to 750?
Well, the reason we did it is because we didn't want, it would include more people and we wanted to have a broader spectrum. So our secondary hypothesis was, first was to show apixaban was better than aspirin for people who had atrial cardiopathy as we defined it. The second was to see whether people who had more severe atrial because we made up the cutoffs. So we wanted to see whether we could arrive at new cutoffs and see whether people who had more severe atrial cardiopathy, maybe they would have a bigger benefit. Maybe not everybody saw a benefit, but those who had more severe atrial cardiopathy would, even if the milder ones didn't. Kind of like what I showed with the left ventricular function stuff. So that's why if we only included the most severe, first of all, it would have taken a lot longer to find those patients. The study would have gone on longer, but also we wanted more of a range. We didn't want the totally normal ones, but we didn't want only the most extreme examples. By having a broader range, we could explore the data more for, those kinds of insights.
So Dr. Sansriti Mishra, who used to be a stroke attending over here, who's now in New Jersey, asking the point blank question, what would you do for ARCADIA patients?
So as I say, at present, antiplatelet therapy, probably dual antiplatelet therapy for up to 90 days, then single antiplatelet therapy. I like to follow the data also because when trials come up, if we're used to doing things a certain way, it's going to be harder to go back and test them as well. So I would say antiplatelet therapy. All those secondary analyses I showed at the end are hypothesis generating. We need more studies to address those kinds of questions. I think there will be a group of patients who don't have AFib, who would benefit from anticoagulation. Frankly, I think the EKG AI stuff is super exciting and will provide a way to choose the right group of patients. It's all about precision precision vascular neurology, precision medicine. Can we use all this information to choose patients who would benefit from a particular therapy, even if the entire universe of patients like that wouldn't? So at present, I wouldn't change my therapy and anticoagulate, but down the line, we could.
Any thoughts about anticoagulation for TIA with AFib? Patients with TIA, not, infarction.
Yeah, so
consider TIA as similar as.
I think TIA is, I think of it in the same, breath as stroke, essentially. Yeah.
So the last question, the relationship between heart failure and cryptogenic stroke, those with decreased EF increase the BNP, be beneficial in that collection. Does that imply that heart failure may role in it?
Yeah, absolutely. We think that heart failure is a major cause of stroke. It's also an important cause of cognitive decline and dementia in people as they age. And there is evidence that anticoagulating people with severe heart failure reduces their risk of ischemic stroke. The problem is it's associated with an increased risk in bleeding, maybe because they don't have the healthiest brains as a result of the heart failure too. So as we develop better and better anticoagulants, we'll probably keep going through these stages where we say, well, let's ask that question again using one of the newer agents where the risk of bleeding is lower. because there does seem to be a benefit on ischemia. It's that we have to deal with the consequences of bleeding.
Great. So we have additional questions on the chat, which will come back later on during the question session for the coffee break. Actually, we have 5 minutes for the coffee break. One more question. For patients with AFib and apixaban and recurrent stroke, no other apparent therapy, no LVO, what's the second choice of DOAC or Coumadin for treatment?
So if somebody so-called fails apixaban, well, that's always a tricky question, right? We used to talk about aspirin failure all the time. And I think we've moved away from using that word failure because it's not the person who fails, it's the medication. And there are a number of different reasons why that could be. It could be the person wasn't taking the medication, so you need to check and see exactly what happened and why. But as an alternative, probably would just use either a different DOAC, or in some cases, add aspirin to the DOAC. There is data from some trials that DOAC plus aspirin is better than single agent alone. There's an increased risk of bleeding there too, of course, but people do take both the DOAC and aspirin, so you can add to it.
Do you switch class between 10A and
Class? Sometimes, yes. I mean, that's reasonable too. We don't have good evidence to suggest doing that, but one could, yeah.
Okay.
I think Steve has a question.
Concluding remarks.
More of a question. Wonderful. Thank you so much for giving us a future look into what's going on. I mean, this is a very important area. But one of the questions I had, and maybe the sample size is too small, and I may have missed it because I went out, I apologize, but did you look at central adjudicated mechanisms of recurrent stroke in ARCADIA such that maybe there was a differential effect based on second stroke being LeCun versus athero versus...
Yeah. No, it's a terrific question, and we're in the midst of those analyses now. We've done the adjudication, but we haven't done the analysis yet. So yes, most of them are cryptogenic, it turns out. Yeah, they remain cryptogenic. Thanks, Steve. I also mentioned you, I think, because I mentioned your name at least once, maybe twice, and you were not in the room. So you missed your call.
Please join me to thank Dr. Elkind again. Wonderful talk. We'll have a break for 5 minutes. We'll regroup at 10 a.m. Thank you.